Clinically defined, the female orgasm is the peak of sexual pleasure, characterized by intense psychological sensations and rhythmic muscular contractions. This graph plots the sexual response cycle: desire, arousal, plateau, orgasm, and resolution. Beginning with baseline desire, the curve scales into arousal and a heightened plateau. At the climax apex, the body triggers the immediate coordination of 4 distinct physiological systems. This coordinated event recruits the brain, the body's bloodstream, and the musculoskeletal system simultaneously. To understand the mechanics, we have to map the exact pathways where the central and peripheral nervous systems integrate to trigger a cascading endocrine and biomechanical response. Analyzing the female orgasm requires discarding simplified anatomical diagrams in favor of a holistic biopsychosocial systems model. The sequence originates in the pelvic region. This area serves as the anatomical baseline and the primary collection point for peripheral sensory input. From here, distinct nerve pathways carry signals to the spine. The pudendal nerve is responsible for transmitting direct clitoral stimulation. This specific pathway accounts for the most statistically common trigger for an orgasmic response. A second route, the pelvic nerve, handles internal vaginal stimulation, frequently associated with pressure applied to the anterior vaginal wall. A third channel, the hypogastric nerve, transmits signals originating from the uterus, governing its contractions. When multiple neural pathways activate simultaneously, such as combined clitoral and vaginal stimulation, the result is clinically classified as a blended orgasm. Regardless of the specific origin point, these peripheral signals converge at the base of the spine and travel up the spinal cord directly into the central nervous system. Diverse physical friction points are translated into a unified, high-bandwidth neural payload and delivered straight to the brain for processing. When these incoming signals cross a critical threshold, the brain initiates a systemic physiological reaction. This dashboard tracks the immediate endocrine cascade. A specific cocktail of hormones floods the bloodstream at the exact onset of climax. Oxytocin drives intense uterine contractions while simultaneously promoting psychological pair bonding. Dopamine floods the brain's synapses, aggressively activating its core reward and pleasure centers. Endorphins induce a state of euphoria while acting as a powerful natural analgesic, actively inhibiting pain signals throughout the body. Finally, prolactin operates on a delayed timeline, releasing during the resolution phase to signal physical satiation and satisfaction. The sheer volume of these hormones represents a significant deviation from the body's baseline resting state. This central nervous system acts as a high-capacity chemical amplifier, converting localized physical input into a systemic neurochemical event. This brain-driven chemical signaling must now translate back into physical, involuntary biomechanical action in the pelvis. This schematic demonstrates the result: precise, rhythmic contractions of the vaginal walls, uterus, and pelvic floor muscles. These contractions operate on a highly specific interval, exactly 0.8 seconds. This timing is the universal biomechanical signature of the female orgasm. Simultaneously, the body experiences extreme hemodynamic shifts, marked by severe spikes in both heart rate and blood pressure. This rapid vasocongestion forces blood to the skin surface, creating a visible dermatological response across the chest and neck known as the sex flush. The sequence forces the musculature into extreme tension, which then demands a sudden and total muscular relaxation as the body drops into the resolution phase. The physical output of an orgasm is an explosive, highly synchronized biomechanical event, governed entirely by strict involuntary physiological timers. Because this pathway relies on the flawless integration of so many different systems, it is highly vulnerable to internal and external disruptions. This framework maps the 3 pillars of variables that dictate the physical capacity for the response. Biological variables, such as age, general health conditions, and baseline hormonal balance, set the physical parameters. Psychological variables act as active neural inhibitors. High levels of stress, acute anxiety, or a lack of emotional connection can physically block the signal from reaching the required threshold. Sociocultural variables also condition the central nervous system's response. Relationship dynamics, sex education, and cultural beliefs about sexuality determine how the brain processes incoming physical stimuli. When these disruptions become chronic, they fall under the clinical classification of female orgasmic disorder. This is explicitly defined as the delay, infrequency, or complete absence of orgasm, despite adequate physical stimulation. Beyond psychological blocks, pharmaceutical side effects, like those produced by certain antidepressants, are a common, distinct biological cause of this system failure. Treating orgasmic dysfunction requires looking past local physical anatomy. A clinician must audit the patient's entire biopsychosocial supply chain to locate where the signal is breaking down. This infographic maps the seamless flow of the complete sequence. Peripheral nerves feed into an endocrine cascade, resulting in a biomechanical output. The immediate physiological benefits of this endocrine wash include a measurable improvement in mood and a reduction in baseline stress. Over the longer term, the cycle provides sustained benefits, facilitating enhanced emotional bonding and improving overall sleep quality. However, the clinical reality is that orgasmic capacity, timing, and specific physical triggers vary radically from one individual to the next. Navigating this degree of biological variance requires open communication and precise understanding between partners. It is entirely normal that not all healthy sexual activity leads to climax. The absence of an orgasm is frequently just a standard physiological variation rather than a medical failure. The female orgasm is a variable component of comprehensive human well-being, representing one aspect of sexual health rather than a strict prerequisite for it.